Welcome to the World Bank Praxis discussion series. I'm Oscar Sabakti. I'd like to welcome our audience here in Sydney, those watching on APAC, online and listening on radio, and everyone watching in Honiara, Dili and Port Moresby. The international community has made great strides in improving maternal health, one of the United Nations Millennium Development Goals, with maternal mortality nearly halving since 1990. Around 287,000 maternal deaths took place in 2010, representing a 47% decline in 20 years, with maternal mortality down by around 2/3 in Southeast Asia and Northern Africa. Still, much more work needs to be done, especially in addressing reproductive health problems, which is the leading cause of illness and death for women of childbearing age worldwide. The numbers are disturbing. Every day, around 800 women die from preventable causes related to pregnancy and childbirth. Every week, some 3.5 million young people, mostly women, are infected with a sexually transmitted infection that doesn't include HIV. And globally, 1 in 5 women will experience sexual violence in their lifetime. So, in light of all of this, how do we help protect women's right to health? How can health systems in developing countries meet the reproductive health needs of their communities? To discuss these issues and more, we're joined by Dr. Samson Baba, Director General for Primary Healthcare in South Sudan's Ministry of Health, the Honourable Dr. Meredith Bergman, President of the Australian Council for International Development, and Michelle Ramsey, Director of Operations and Development at the World Health Organization Collaborating Centre for Nursing, Midwifery and Health Development at the University of Technology, Sydney. Thank you all for joining us. Firstly, Michelle Ramsey, if we could start with you, how is the maternal health development goal being achieved, both regionally and worldwide?
I think really it's good to go back to the beginning a little bit and explore the Millennium Development Goals. And I think the Millennium Development Goals were set up in 2000. And there were many of the Millennium Development Goals that had global funds attached to them. So a lot of movement and traction has been gone through on HIV, malaria and other areas. But I think the 4 main ones that really affect reproductive health are Millennium Development 2 for education, Millennium Development Goal 3, which is around women equity, Development Goal 4, reducing child mortality, and number 5, obviously the reduction of maternal death. And I think we need to do some more work on these, and I think there's been some areas where we have had some traction, but there's some big areas that we haven't. For example, it took until 2008 for the Millennium Development Goal 5 to actually have universal access recognised for reproductive health. And we didn't get a women in the UN until 2010. So we recognise that there has been some traction, as you said at the beginning, but in our region, especially in PNG, we still have a long way to go, where we have 733 women out of 100,000 dying annually. So we still have a long way to go.
Samson Baba, as we've heard, the UN Millennium Development Goal, or MDG, is to reduce maternal mortality by 3/4 and to achieve universal access to reproductive health. What's the situation in South Sudan? Because you've pretty much had to start from scratch after 2 significant conflicts, haven't you?
Well, first of all, the development of Millennium Development Goals were set without consultation of the countries. So these goals were set, some of them are too high for some of those nations which are poor and some of which were having problems from within internal conflicts. So we were just co-opted into it. We didn't have our own say. So that was a mistake from the beginning. Now, I do know that when the Global Fund was instituted for malaria, TB and HIV/AIDS, I think it was just to answer some of those problems that were not addressed from the beginning. But for us, because we are the newest country on earth now, we are only about 2 years and some 2 weeks old. We came out of 2 severe wars. There is no way that we are going to achieve the Millennium Development Goals. But the good aspect is that we have learned that there are certain things that we must consider and we must strive to achieve. And maybe within the next 2, 3, 4 years, we will be able to achieve 1 or 2 of those, because currently we cannot. And the reasons are quite obvious. We have serious shortage of human resource. We have all the sectors of the government are just developing. We are developing the policies, the guidelines, and the protocols. So it will take us some time.
Meredith Bergman, globally there's been a lot of attention to address reproductive health, but what do you see as being the challenges to actually keep it on the agenda?
Well, first of all, we have to accept that sexual and reproductive health is really a bit of a hot potato in world politics. In America it was called the global gag, and in Australia it's called the Harradine guidelines. But basically conservative governments, the Republicans in America and the Liberal Country Party, National Party in Australia, when they come into office, they bring in this, well, as I say, it's called the global gag in America. It says that any aid and development money which goes to an organisation which even counsels or talks about abortion has to stop. So you might think that that is not going to have a huge effect, but what it really means is that money for family planning services and for quite a lot of sexual and reproductive health services just dries up. And in the period where there was a Republican government in America and a Conservative government here in Australia, money that went towards family planning just dried up and had a huge effect. One of the reasons I continue to love Barack Obama is that on his very first day as a legislator, when he came in as president, he revoked the global gag. And I still think that, you know, he can do lots of terrible things, and I'll forgive him simply for that, because he actually saved millions of women's lives. Don't forget that a woman dies every 2 minutes from an unsafe pregnancy. And the second point, which really is a good indication of what a hot potato the whole issue is that Millennium Development Goal 5, which was agreed on in 2000 with all the other development goals, simply said reduce by 3/4 maternal deaths between 1990 and 2015. That was all it said. And then after a huge fight in 2007, what was added was these words: achieve universal access to reproductive health. Well, you can tell that a huge fight happened in order for those words to be almost meaningless. But they're there and we have to stick by them. So really, we can never rest on our laurels. Yes, huge strides have been made, but there is still a huge need for proper family planning. I mean, 222 million women a year go without proper access to family planning.
Michelle Ramsey, what are the aspects of this Millennium Development Goal that haven't been addressed?
Well, I think for us, one of the issues was that reproductive health was really talked about in a very high-level way, especially within WHO and globally. And also there was a lot of focus on traditional birth attendants, community health workers, but the main group, the most expert group who deal with midwifery and reproductive health are the midwives. And they really weren't in the discussion around the Millennium Development Goals for the first 10, 11 years. And so recently, as some of the targets haven't been met in many countries, or they're realising the lessons learned along the way, as our colleague Samson can turn to, midwifery is finally coming into the play. In our region, in the Pacific and Papua New Guinea, where we do a lot of work within WHO, it's not just midwives, but it's nurses with midwifery skills, because many of our countries in the region are very isolated with very small health workforces, and so they just don't have the capacity to have the number of midwives we'd like. So at the moment we've got to be sure that we're looking at both angles, but midwifery is the most cost-effective way with the best skills to deal with the midwifery issues and reproductive health.
So as you say, I guess this aspect of midwifery is being neglected in this training, but what sort of training do they need to receive? Because it's not just a simple 6-week course, for example. You're advocating for more proper training, aren't you?
I think we recognise that there's a variety of education that needs to happen right from word to go. So we need more education for women, for starters, so that they can become well educated, to enable them to understand the issues around maternal and child health, to be good mothers, to understand the issues around going to facilities. But then if we have well educated women, we know the majority of nurses and midwives are women. So then they can go into higher education and become a nurse or midwife. We also need to empower the faculties of health around the region to enable them to produce good quality nurses and midwives. And we're actually working in PNG with all the 4 midwifery schools, and AusAid have just enabled a 5th one to be off the ground, which is fantastic. And we have 9 what we're calling clinical midwifery facilitators working alongside and behind our midwifery educators to capacity build the educational institutes. There's a lot of work that we need to do, but it's empowering those institutes to make sure we have good quality midwives produced within the region. In PNG, we only have about 200 for a population of 700. We've got a long way to go. AusAid is bringing in scholarships, so we hope to double those numbers in the next few years.
Samson Baba, you've got quite strong views, don't you, in terms of how to train midwives and people with these skills. What's happening in your country, South Sudan?
Well, it's not only training, because you have to look at whom you are training and at what level, because you might train these people even to a diploma level. But if the infrastructure for them to practice is not there, if the equipment are not there, then you are just building a monument in the air. Because simply, out of the, let me say from 100%, 85% of the ladies will deliver normally, irrespective of what the situation. It's only the 10 to 15% who will need assisted delivery. Now, and if you need to reduce the mortality, or right now some of those complications, then you have to address that issue. Now, for us in South Sudan, we have only 40 qualified midwives in a population of 8.5 million. That's the whole population. And our population is 60% ladies, obviously because of the war. And some of these ladies, once they conceive where they are, they will not get to see any health facility, because the only health workers that they see are their aunts, their mothers, their sisters. And because we also don't have a referral system, we are still starting. Now, if this lady needs to be assisted, then we cannot, because we cannot refer her. So the best thing that we are trying to do is that we need to train the people at the low level, but we have realized at the low level, community health workers, or what we call the maternal health workers, they are not helping in reducing the maternal mortality. If anything, they're actually adding to it. And that's why we have stopped training community health workers and maternal child health workers, because they become so bold that they will be pretending to be screening the ladies, and then they detain them. By the time that they release them, it's already too late, and they start panicking. So it's not only that, because the issues of reproductive health are both political and developmental. The more developed you are, the better you can solve the problems.
Michelle, Ramsey, you've worked extensively in Papua New Guinea, in some of the most remote places in the world, really. How does that situation compare to Papua New Guinea? Is it even feasible to have trained midwives in some of the areas that you've worked in?
I think there's a lot of synergies between what Samson was saying, but I think 50% of women in Papua New Guinea actually give birth outside of a facility. So I think we have a long way to go. There are lots of very good structures, and there's lots of really good training going on. For example, there's a reproductive health training unit that's set up in partnership with the National Department of Health. And I think we're trying to build the skills of workers across P&G to address this gap at the moment, because we have a long way to go. We have so few midwives. We're not going to be able to solve these problems quickly. The topography, the transport issues are really difficult. Luckily, with companies like Digicel, communication is getting better. It's the first time in a long, long time that we are beginning to get communication throughout the Pacific, and that is helping with health workforce being able to communicate. But I think the most important thing that we've been talking about is the skills that a health worker has to ensure they understand the referral and decision-making process so that they know when to refer a woman in need quickly.
If we could look at this issue of family planning, which I guess is a reproductive issue, and Meredith Bergman, you touched on the fact that governments and faith-based aid agencies could even impede efforts when it comes to family planning. But can I ask all of you, how is family planning being addressed in the context that you've worked in?
Well, I have had a personal experience of talking about it in Timor-Leste, where we were up in a very isolated area, and my colleague and I were talking to a group of men and women about access to condoms. That was the particular sort of family planning that we were talking about, and I could see all the women's eyes light up, but they wouldn't ask any questions. And it was only later, when the men were not in the room, that we actually got all the questions that we'd expected. It's it's very complex. It's not necessarily to do just with religion. It's very cultural. It's to do with men's view about what constitutes a proper family, and to many men, 10 children seems like a good idea, and there needs to be really good public education about the effect that big families have, not just on the health of the woman and the children, but the fact that there's a study from Bangladesh which shows that families which undertook family planning were a third wealthier than families that didn't, and women who could space their children saved children's lives. It increased the safety of children's lives by 46%. Things like that need to be part of a public education campaign.
Samson Baba, is South Sudan encountering these problems with family planning? Presumably there are a lot of cultural sensitivities that are affecting these initiatives.
Traditionally, we have a family planning system that is embedded within the society. For example, if your spouse delivers, then you are not expected to be in contact with her until the child is almost 2.5 years or 3, running about in the compound. And that brings in another element that most of the men will want to get a second or a third wife. The issue of polygamy comes in. And then and the wealth in the family is considered how large it is. That is the wealth of the family. However, in various communities, there are problems, because you might look as if the woman is a beast of burden, because in some communities where water is rare, especially the dry season, the woman gets up very early in the morning, around 3, 4 in the morning. She goes for hours. She might come back around 3, 4 in the afternoon with 15 or 20 liters of water. She puts this one down. She goes and looks for firewood. She sets the stage for cooking. She goes on cooking, and then, unfortunately, when the food is ready, the best part is served to the men, the other for the children, and then the women will end up eating the remnants, and sometimes they have to go hungry. And with all this, she is supposed to satisfy her husband's conjugal rights. And then this is a cycle continuously. Now in that, because she is being deprived from good feeding, and some cultures, they're not supposed to eat chicken or goats, and these are things that even aggravates the matter. Therefore, even if she delivers, the children are not going to be healthy, because she is not there most of the time to give them the good nutrition that they need, including issues to do with malnutrition within plenty. You have all those things, but you don't know the balanced diet. And also, men tend to think that women are their properties because they have to pay a bright price, and the woman has little say in her own health. And these are the things that need to be addressed. And that, do you address it politically or do you address it developmentally? Now, politically, in most of these cabinets, you find there are men, and then they will resist anything to do with getting the women to come near and have a say. Now, but we are trying to sort that one out because now we have within our constitution, at least 25% of the cabinet and in the parliament has to be ladies. And that's why that will solve it politically. But developmentally, we'll have to concentrate on bring up the girl child and give her all those that need it. And in South Sudan in particular, we have a high dropout of girls from school because once they have their menstrual cycle, then they don't go to school. Now, we are now thinking of introducing sanitary towels that will be given to them so that they can attend school just like the boys.
I think this leads well into the next question I want to ask. Meredith Bergman, you're quite passionate about having more women in power. You think that this will go great lengths in addressing these problems with reproductive and maternal health. How so?
Look, all practice shows us that unless you have women in the decision-making bodies, issues to do with women's health, and issues to do with domestic violence, just fall off the agenda. And particularly in the Pacific, this is hugely important because the Pacific has the worst representation of women in parliament in the world. It averages at about 3% women in parliament. 4 of the Pacific countries have no women at all, and most of the rest only have 1 woman. And it simply means that women's issues aren't addressed. The one country in the region that has a significant number of women is New Caledonia, and it's actually part of France, which is why it's ended up with a large number of women in the parliament. And they have introduced very good women's legislation to do with women's issues. So until, it's a chicken and egg situation, of course, but until you get women into decision-making bodies, there will be no good legislation to do with women's reproductive rights. Most developing countries have no legislation that says that it's wrong to beat your wife. And that is very definitely part of reproductive health because it's often women give in to having sex because they fear being beaten if they don't. And often it then results in children arriving every 10, 11 months, and of course, terrible results for the health of the women.
Michelle, Ramsey, in your work in the Pacific, how important is the involvement of women in this whole process?
Sure. I'd probably like to angle it's not just women, but it's the leadership. We've worked in the Pacific for many, many years, and one of the groups that actually asked us to be a collaborating centre, World Health Collaborating Centre, was the South Pacific Chief Nursing and Midwifery Officer Alliance. So it's a bit of a mouthful, but what that means is it's the chief nursing and midwifery officers, their leaders, the regulators and the educators of the Pacific. And at the recent 10th Health Ministers meeting in the Pacific in Samoa, that group actually lobbied really hard with the health ministers to say that it was really important that we have strong leadership throughout the Pacific to make an impact on these issues. We have many countries in the Pacific that don't have a chief nursing and midwifery officer in their ministries of health, and that means there's no power base, there's nobody to actually push these issues forward around the reproductive health within the health ministries. So luckily the health ministers supported that recommendation, because we have seen in many of the countries in the Pacific that don't have strong leadership, these issues are struggling. Vanuatu doesn't have a chief nursing and midwifery officer, nor does PNG at the moment, although we're getting a lot of support. So it's really, really important to have this leadership, especially in the Pacific, where you have small island states that have small pools of health workforce that are isolated and have to cover really big rural and remote areas. Thank you.
So, Michelle, what is working then? We've talked about a lot of the problems, but you've also, I guess, you can highlight some of the positive things that are happening, some of the initiatives and projects. What's happening that works, and can they be sustained?
I think our experience is the relationship we have with our colleagues from the Pacific. We've worked with them for a long time, and I think we've learned that as our colleagues tell us constantly that we need to be culturally intelligent, so we need to understand their context and work alongside them. And it's building a trusting relationship that we've done for many years, so that actually all we do really is provide support and information and resources where we can, but actually it's their decision making. They make the decisions at their local level to make the change. There's no point us coming in and providing resources or an individual if we're going to remove that person. So we've worked very slowly with our colleagues throughout the Pacific. We've been very successful with the AusAid ALA programme, for example. We've had 82 fellows through the WHO Collaborating Centre, and our colleagues in Tonga at the moment are working on a family planning policy within their ministry. They've been doing quite well, but they want to improve the family planning aspect within the country, so that we've been supporting them along the way. And we have many, many different projects in PNG, as I already talked about, the Maternal and Child Health Initiative that's running for another 2 years with AusAid.
Samson Baba, what initiatives are working in your country? And as we've heard, South Sudan has the highest maternal mortality rate in the world, but what sort of projects are working in your country?
Yeah, our maternal mortality is 254 per 100,000. 2,054 per 100,000 is the highest. Now, what we're doing is that we are trying to train maternal child health workers at least certificate level, and then they have to be able to screen ladies, and that we encourage antenatal visits. But we have realized this is not good enough because our infrastructure is very poor. Referral system is very poor. The roads are bad, and we are still demining roads. And besides that, the level of training, because we had wars for almost 5 decades, and then the pool from where you get persons to train is very little. And then we were supported by UNFPA. They brought in 17 UN volunteers who are midwives, and they were posted all over South Sudan. Unfortunately, where they are posted, they're supposed to stay within UN compounds or NGO compounds, and therefore they are concentrated in the towns. But our population is 90% rural. So we have set up some training school supported by JICA, and then we are trying to set up 3 or 4 schools for midwifery training and other mid-level cadre. We have calculated that at the current rate that we are training, which is almost about 60 to 120 per annum, it will take us 66 years to saturate the market with the qualified midwives. But if we were to train 200 per annum, then it will take us only 10 years. And our problem is also all the sectors need a heavy investment. And from 2006, when we had an agreement, a comprehensive peace agreement, our budget was 7% of the GDP. Right now, as I'm talking, he's dwindled down to 2.7, and we have austerity budget. Now, obviously, if you don't invest heavily in health, you won't see the returns. And if you invest heavily in the military, which tends to be the situation, then it even aggravates it further. And these are the issues that we are coping with. And most people don't see health as something that is multi-factorial, because health is not the domain of the Ministry of Health alone. You have to have agriculture, you have to have animal resources, you have to have good housing, you have to have running water. In our city, we don't have a sewage system. You have to buy 200 liters of raw water from the river, and you pay almost $2 to $3. So these are things that are both developmental, and it will take us a long time. But if there is goodwill from the politicians, and then something can happen. We essentially are not poor. We have a lot of natural resources. We have oil, we have uranium, we have gold, good sources of water, agroforestry. We are not poor, but we need to use our resources carefully to develop the other sectors, because if we're only developing oil, then at the end of the tunnel, we might be following what Nigeria has been doing and not what Botswana is doing. So we have to choose the right path, and I think we'll have to make that decision.
The UN's Millennium Development Goals are supposed to be achieved by 2015. Samson, in your case, you think that's a bit ambitious for your country, but a lot of talk is now happening on post-2015. What would you all like to see on that wish list, or what still needs to be discussed when it comes to reproductive health and maternal health? Meredith Bergman, if you could start.
Well, I still see it as an ongoing battle for what we have now. I mean, let's face it, unfortunately the maternal health MDG is the one on which we have progressed worst in the last 15 years. So I see it as a continuing battle on that front. The Australian government, I think, has got really into the mojo of it all, and have made a number of announcements about funding female health workers and funding a domestic violence campaign in the Pacific. They have appointed an ambassador for women, Penny Williams, who has done a lot of work on advocacy, particularly in the Pacific. So I can see really good things happening in our area in those aspects, but really I think it's an ongoing battle with some very, very conservative countries to make certain that the United Nations continues to see reproductive health as an important part of whatever goes beyond the MDGs in 2015.
Michelle, Ramsey, what's your opinion? What needs to be discussed post-2015?
I think there's been lots and lots of discussions, and the discussions are ongoing, and I think it's really important that we keep focused. I think the targets were useful in some senses because it meant that our colleagues in the region started to collect data. So for the first time we're beginning to get some idea on where we are throughout the region. However, that data is still sporadic and we need to move forward. I think there's about 12 global interventions that have been agreed on, and the two that will save lives the most is to increase family planning, and that's quite clear. Everybody realises that's one of the most cost effective, but also to have a strong health workforce, and we truly believe that's midwives. We need to increase the number of midwives to address the reproductive health issues and to save women's lives. But I think the other one that's come to light recently is the one about reach, to make sure that health is equitable across all our region, and we're very aware that the poorest of our colleagues still aren't getting the health that they require. And I think with urbanisation, that's causing a big problem. Even in the Pacific, which has very small urban sites comparatively to Asia, for example, we still have urbanisation issues, but we also have very, very remote rural areas. And I think, like Samson was saying, I think how governments in the Pacific and our region relooks at how they spend their dollars on health is really important, because if we're to reach the very poorest and the people who are giving birth in the 50% in PNG who don't get to facilities, we've got to think of some very innovative ways to move forward.
Samson Baba, what's on your wish list post-2015?
Well, post-Millennium Development Goals. But the first thing is this. If we look back at the Alma Ata Declaration of 1978, the primary health care, by the year 2000, before we moved to the MDG, did we achieve it? That's a wish list. And I hope we will not just be developing other projects, meanwhile we have not completed. And my fear is 2015, maybe very, very few countries will have achieved the Millennium Development Goals, and most of those in sub-Saharan Africa will still be groping with the same problem. Now, if you're going to develop something, we should develop it having achieved what we have set for ourselves. And it is not, there is no need to be jumpy left and right. No, it's not going to help us. And in sub-Saharan Africa, and especially in South Sudan, as I said earlier, we are not going to be able to achieve that one. And if they are going to develop other developmental programs, we will be lagging behind. But I think that will be very unfair, because the whole thing is that the developed countries, they go on setting standards and they move on. And I hope they will be able to see it and reflect and say, okay, if those ones that have not achieved, well, how are we going to solve those problems? How are we going to move? And if we are going to develop other projects or some ideas to move forward, what are those things that we need to do? And how would we bring those ones that are below to come up? So it's a debate, and I hope it will be a stage set so that all of us will participate and then be a part and parcel of what we are going to do.
Thank you, Samson Baba. That's a lot to digest there. But now let's open up to some questions. So if you could all think of some questions, I'm sure there are many. But to start off, I've got a question here from Papua New Guinea. It's directed at Michelle and Samson. Village birth attendance is a program that's been operating in PNG. Can programs like this be integrated in formal health training?
I think it's very interesting that the village program has been available for a while, and I think the important thing is it needs to be linked through. And I think that's the thing, that the message that I've always wanted to get across is the village birth attendant should link through to the community health workers program, and the community health workers program should link through to nursing and midwifery. And I think sometimes those links aren't as strong as they could be. And I think in a country like PNG, where we do have the majority of the women giving birth outside of the normal facilities, because the facilities aren't available, the village health workers are important. We can't ignore them, but we need to make sure that they're linked through the system so that they understand that decision-making and referral process, so that we don't get into a situation where they're making decisions that are inappropriate or unsafe for the mothers. And I think that's a really important message, that we actually all work together to ensure the health of the mother and babies, really.
Samson Baba, you've said you've completely stopped training those at the lower level when it comes to these issues. Do you think there's still a place, though, for training at that more local level?
Yes. You see, first of all, you have to go to the grassroots, and you have to be able to approach at household level and even individual level within the village. However, if you are doing that, at that level, you must be able to introduce a sort of midwives or maternal child health workers who will be able to tell which lady will need assisted delivery and which one does not need. And that also with the home education, nutrition education at that level. Now, it should be linked up, and I agree with her, it should be linked up with the health system, that once you screen these ladies, not only by going and doing the normal screening, talk to them about health issues within the family, because there are many other things that come into play. And then you move the process further to a health center, irrespective of whether you call it a health center or a rural hospital. And from there, there has to be an institution that will receive those ladies that will need assisted delivery. Because those who will deliver normally, they will deliver anyway. But those who will need the assisted delivery, then the comprehensive primary health care, where probably there is blood transfusion and maybe there will be cesarean, all these things should be availed. And if they're not available, then some of those ladies who will need assisted delivery must be moved closer to the facilities that will be able to help them. That means that maybe transporting some people, some ladies from one location to another one, so that by the time that they are in labor, they're already within a health facility that can help them. And that will help. But that has got to be worked well with the health system and a communication system, that people can inform people that we have this situation, we need help in ambulance, or we need help in terms of a clinical officer. So it has to be worked, and it has to be embedded in a policy, because if it's just left like that, it will not work.
Do we have a question in Sydney?
And Cynthia Hunter, medical anthropologist in the School of Public Health at the University of Sydney, plus development studies in anthropology at the University of Sydney. My question is to Michelle and Samson. I'm really pleased to hear you make the links between the training of midwives and health workers and the health system. I was wondering if both of you could elaborate a little bit on that interface between the training systems and the health systems, in particular access to rural health clinics.
Sure, I can start if you like. I think it's really, really important. I think one of the things that we're finding is that we're starting with the aid of AusAid to improve the educational institutes so that we can get better qualified nurses and midwives in PNG, for example, but the numbers are still really small. But that alone is no good unless we ensure that we have the resources in the rural and remote facilities, because what we're finding is that our colleagues may go back to those areas and they have no resources to actually deal with the reproductive health issues. This has come up again with another project we're involved with the reproductive health training unit. So I think it's a real mixture and it's a really hard debate. AusAid have just done a really amazing job of sending out pharmaceutical and reproductive health supplies to all the rural and remote sites in PNG. But having visited many of them, I've seen them piled up, and I think the Burnett Institute is now involved in some research to see how those supplies are actually being utilised, because again it's about education. If the individuals in the rural and remote settings don't understand how to utilise and use the supplies that they've been given, we're still in the same circle going round. So I think huge improvements are being made, but I think we still need a long way to go.
Yes, I think we have to think outside the box. The first thing is this: if there is no development going on, and if there is no investment that goes with it, then the status quo will continue. I will tell you, for example, in South Sudan, 80% of the health service is being given by non-governmental organizations. They get money from the donors, and then they write their projects, and then they implement it. Unfortunately, they do not give the government accountability of the funds they received and how it has been utilized. And then that has a part to play, because you can only improve on the training if the level of education is also improving. That means that education in general has to improve, transport in general has to improve, housing and all those. Because at the village level, if people continue to stay the way they're staying traditionally and there is no improvement, and if you don't concentrate on the girl-child education, then you are fighting a losing battle. So it has to be done concurrently so that the training that we do keeps on improving with the level of education. So if you're taking people who have just gone to school for 6 years and after another 2 years, you can upgrade it. You take people after 10 years of education, then the standard will improve, because you cannot give what the person at their own level of understanding cannot understand. So all these things come into play, and essentially is that the budget has to be commensurate with what you're doing. And what we experience is that we are not getting that budget. And if you have to rely on donors continuously, then when they exit, you remain where you are. So these are things that our governments, especially in sub-Saharan Africa, will have to understand. For you to reap the benefits of what you are putting in, you have to invest. Without investing, we won't move forward.
We've got a couple of questions from Solomon Islands on this issue of women leadership. These questions are from Meredith. Can you, Meredith, explain to us or give us an example of where a country that has women participation in Parliament, how has that reduced these these issues of reproductive health and maternal mortality? And the second part of that question is, are women parliamentarians the only way to achieve these outcomes?
Well, I'll answer the first one, the second one first. Yes, there is no evidence of any country really anywhere where they have moved to having good legislation on domestic violence and good healthcare services which put women at the centre of, of the whole business. There's no evidence that that happens without having women in the parliament. Now, I admit that they might both be the same, have the similar. It might be that they are just both effects of the same cause, but it can't happen. You cannot have a proper health system and decent legislation without having women in parliament. And the problem with, for instance, the Solomons is that there's only one woman out of 50 members of parliament. For a while there were no women at all. There are some very, very fine women who have stood for parliament in the Solomons. It's not like they haven't tried to, and they simply don't get elected. And there are a number of reasons for that, but I won't go into that. Now, as I said earlier, I looked at New Caledonia because it is also a Pacific Island state, and they do have a considerable number of women in their parliament, and they have, for instance, their domestic violence legislation is very good, and some of their healthcare initiatives have been very good about putting women at the centre of their healthcare system, and I think that is quite a good example because it's a fairly similar sort of state to the other Pacific Islands. I really think that the male leaderships of our Pacific Island neighbours need to look at having designated seats for women parliamentarians, because if we wait until it happens naturally, as they say, we'll be waiting another 50 years. Over half of all countries in the world have some form of mandated designated seats for women, either at the party level or at the constitution level. And I think for the Pacific Island states, which really have a terrible, terrible record, to resist having designated seats is just wrong. I mean, Tonga has one woman, Solomon's one woman, Samoa has 2 women, Nauru, Micronesia, Palau and Vanuatu have no women, Tuvalu has 1 woman, Marshall Islands has 1 woman, PNG has 3.
Do we have a question from Sydney? Yes, ma'am.
I'm Dr. Christian Yapanmon, now currently PhD student in Uni Sydney. I'm from Myanmar and worked as a previous UNFP and OSAID also. So thanks for a very interesting question. My question is when you are talking about, I think the situation are very similar to us, more or less. The question is when you talk about there may be the lots of improvement trying to do us. How about the vertical? I feel like the NGO are 80%, and why this government don't have this and that reason resources not come all. Instead of vertical program, how about the integrated program set it at, or how about the collaborated effort to reduce the maternal mortality and morbidity rate? And then the second thing is gender problem is more or less the same with our background. So is any improvement rather than the education? I mean, the education, there may be a system in place, but how about to cover all the including the rural education? And that one is when you talk about the primary healthcare worker, let's say the training of the primary healthcare worker. How about I believe there may be attrition and the undercoverage in the war zone or the severe area. How about the system for the emergency in the crisis situation? Thank you very much.
Thank you. So the question was about individual versus collaborated efforts, as well as education. What about assistance in emergency and crisis situations?
Certainly, I agree with you. I think we've got to look at a variety of ways. I certainly know in emergency disaster, some recent work we've done throughout the Pacific looking at the adaptive capacity of individuals within the climate change context. We've discovered that our colleagues do need to work together very closely, and that we need health to be integrated more across all the systems of the health sector. But we have recognised that nurses and midwives are often the first port of call in disaster scenarios, and are still not recognised. It's often almost like they're invisible. They're there, they know how many pigs are in everybody's garden, they know how many people are pregnant, but they're often not integrated. I'm not sure if I've answered your question correctly, but I was trying to grasp exactly what you were asking. I hope I've started anyway.
Thank you for that. Dr. Baba, we've got a question for you from Papua New Guinea. Faith-based organisations in the Pacific are important in working with communities. What has been the experience in South Sudan when it comes to these organisations?
We have a long history with the faith-based organizations, right from our independence or even before the independence. We have the church missionary societies, and there are a good number of them, including World Vision we have, and others. Yes, they do a good work, but the issue is it's not only about good work. What is it that the faith-based organization can help? It should not only be anchored on religion and the do's and the don'ts. I think the activities of the faith-based organizations should be to help. It's good if you want to propagate your religion, but propagate it without encroaching on the rights of the other persons. And that has not happened. So far in South Sudan, we are collaborating very well, and we have a number of good, actually good, big faith-based organizations, and they're helping us in setting some agenda in terms of health, and others in agriculture, others in veterinary services, and we have no problem. And for us in South Sudan, we have no religious animosities. Our population is 98% Christian, Catholics, Anglicans, Seventh-day Adventists, and we have a population of 2% who are Muslims. And we intermarry freely. There is no animosity. So I think as far as faith-based organizations are, we are doing quite fine.
Michelle Ramsey, we've got a question from Papua New Guinea. Village birth attendants do not have the special skills to save women. Can we build more midwifery schools in PNG? At the moment, there are only 4.
Certainly, I know that we're looking at having a 5th one, but at the moment there's 22 provinces in PNG. As we've already discussed, the topography and geography of PNG is incredibly complex. Most transportation is about planes, so like your scenario, getting around the country is really difficult. So if you've got 22 provinces, you've only got 4 midwifery schools. There is a 5th one coming on board. There's been funding allocated from AusAid, but I think it's absolutely desperate. There's a desperate need for us to have more midwifery and nursing schools. We only have 8 nursing schools, and in PNG, 5 of those are faith-based. So the state government only has 3 of those. So I think there's a big need to increase our educational institutes for actually all health workers in PNG.
Okay, we've got time for a couple more questions. Is there one in Sydney? Ma'am, yes.
Yeah, thank you. My question goes to Samson from University of New South Wales. My question is, I know you have a few midwiferys, and the challenge that I see is retention of these staff, since there are very few. What mechanism are you applying to make sure that you retain the staff, given the overwhelming roles and responsibilities they are faced with, and then the delicate work they handle? Thank you.
Thank you. Retention of staff. In fact, the non-governmental organizations are poaching our staff, because our salaries are the salaries of the NGOs are almost 4 or 5 times what the government offers. So we have this brain drain, if I may call it, but it's good that because they work from within, people move from the government sector to the private sector. And that has left a number of health facilities without staff. Now, what we have done, we have introduced harmonization of the salaries. So this we have agreed. In fact, it has already been signed off. We have agreed on a ceiling from the government, has been moved up, from the NGO has been moved down, and then we have now what we have agreed upon, and is what is going to work. But that also does not prevent those individuals who will want to go out of it, because it's market forces. And then I think it will be unfair for us to deprive people who feel that they can make more money from living. But we have one way of bonding some of the health workers whom we train. If we send you for 2 years or 3 years of training, then when you graduate, you come and serve us for 2 to 3 years. And we do it by getting your certificate and all your documentation. We lock them up in a safe. By the time that you're through, we give them to you, and then you can move.
Which is something we've got in Australia in terms of training rural doctors. So it's not, we probably don't lock their documents up, but it's a similar concept, isn't it? There was a question from the front row, ma'am.
My name is Xia Hui, a senior economist from the World Bank. My question is regarding how the husband's place in this family and reproductive health, because women is often the target of the initiatives. However, many evidence has shown in other parts of the world, like South Asia, that husbands actually play crucial roles in both family planning, access to prenatal and postnatal care, as well as broadly facility or institutional assisted delivery. So in that sense, I was wondering, either in South Sudan or in the Pacific region, are there any examples to involve husbands in the decision process or trainings in terms to achieve better maternal health?
Precisely, we have not done that, and I can see a lot of difficulties, because men tend to be defensive of their positions, and they think that women, especially married ladies, are their property. But I believe that what we should do is that spouses might get together and be counseled together to be told what to do and what not to do, and to cultivate the relationship of respect and understanding. And it will take a long time, and it is not going to be a year, 2 years. It will take some time, because there are cultures involved, and to change cultures is not easy. But I think the right way is for us, because what is it that keeps us or propagating this animosity towards ladies and this sense of ownership of another human being? No. If you enter into relationship, marital relationship, I think it's supposed to be based on love. But anything other than that then becomes all. But if within a family, the father is battering the mother and the child is watching, for him and for the boy, he will think it's a normal thing that the father must do. And the daughter of this couple will think, okay, if my mother is being beaten at that, maybe when my husband will be beating me, it's a normal thing. So we have to change that cycle.
And I think we've got time for one last question. This one's from Save the Children in Papua New Guinea for Michelle. PNG has about 50% of women giving birth outside of health facilities in remote and rural areas. What's the way forward? Could it be building waiting homes for pregnant mothers near a health facility until they give birth? Or are there other ways to work with traditional birth attendants that can address this issue?
Yeah, it's complex. I mean, I think we've talked over and over again about the skills impacts and making sure we have the right skilled individuals, but we also have a lot of women dying in PNG, so we do need to think innovatively about a new approach. I think the important thing is to remember the connection between the different health workers and involving the village workers. I don't think I can honestly suggest a way forward. I think it's incredibly complex. I think the national National Department of Health is trying to grapple with many of these issues, but the National Department of Health in PNG has huge human resources for health issues itself. It doesn't have enough health workers working in the National Department of Health to make these decisions. The good thing that's happening in PNG is that there is through its new organic law, there are provincial health authorities setting up which are having much more ownership of the health issues across PNG. There are 5 on the go at the moment, so for the first time ever the decentralisation means that there is one central body in that province that's looking at all its health facilities, because in the past there was a division of who looked after what, so that a lot of the rural and remote centres were looked after by the national department and not supported locally. So I'm hoping that those new structures will strengthen, and certainly the experience we've had with working with provincial health authorities recently and the training that they're looking at will improve and help the resources of those rural and remote areas and pull everyone together, but it's very complex.
Do any one of our panellists have any final thoughts on this very weighty issue?
I think the people, the government, the parliamentarians, the politicians have to appreciate one thing. They can say things that they say. At the end, they have to appreciate what will help them in future. They have to advocate for rights of women. Policies have to be enacted. Funds have to be availed. Training facilities have to be done. And then let us look at the woman as the center of how our lives revolve around it. If we do not recognize that fact, then we are still a long way off, and that can be done better by the politicians and then the people who develop the policies.
Meredith Bergman?
Look, I think that the most cost-effective way to save a lot of lives is to put real money into family planning programs for the 222 million women who want family planning and can't get it at the moment. It will cost $8 billion a year. Now, $8 billion might sound like a lot to us, but in the world context, it's a drop in the ocean. And for that we can get proper family planning facilities to those 220 million women who need it.
Michelle Ramsey?
I guess the last thing that I'd have to say is just empower the nursing and midwifery voice in the Pacific especially, and enable stronger education. I think both of the points that my colleagues have said are absolutely very, very important, but I think it's almost like the nursing and midwifery voice has been invisible, and I think it's about time it became visible. Thank you.
And that brings us to the end of our discussion. Can we please thank our panellists, Dr. Samson Baba, the Honourable Dr. Meredith Bergman and Michelle Ramsey. I'd also like to thank everyone joining us either here in Sydney or from afar. And remember, you can watch this or any of our other Praxis discussions at worldbank.org/Praxis. Until next time, I'm Oscar Sabakti. Thanks for joining us. Bye for now. Well done, everyone.